And I met Peter in International IOTA in Denver last year. We were at Cyril's house when we were there out there, right? And he has been seeing my
Dear doctors, we are live.
So, hello everyone. Am I audible?
Yes.
Yes, sir. Please.
Yes, sir.
Hello everyone, and welcome from Delhi Orthopaedic Association on the series of these Sunday evening events that we have been doing for over 2 months now. And today is a grand round on tibial plateau fractures, in which the discussion is going to be case-based, meaning that we would be presenting cases and trying to bring out the same very principles which we normally follow to take care of these very difficult injuries. We've been doing these grand rounds, and they have been particularly very popular. The last one was on elbow fractures, which had a visibility viewership of almost around 1,500. Today, again, the platform has been raised by Omnichorus, and we are also co-hosting through OrthoTV. So happy viewing, and I hope you enjoy today's session. We have a galaxy of experts here, and the best thing is that today's moderator is none other than Dr. Vivek Trikha, whom all of you know as an expert trauma surgeon from the Apex Ames Trauma Center. So I would hand it over to Dr. Vivek Trikha, who would be conducting this evening's program, and hope we enjoy sharing the different type of cases we're going to see. So Vivek, over to you.
Thank you, Lalit. I hope I'm audible, and for that introduction and for the opportunity for me to be a part of this wonderful gathering, as well as a very important topic on tibial plateau fractures, which has been organized by Delhi Orthopaedic Association. Let me have the pleasure of introducing all the faculty first, and then we will go on to the cases. And first of all, it's my honor to introduce Professor Dr. Peter Giannoudis, who is from the Leeds Teaching Hospital, NHS from United Kingdom. I think that nobody in India or in this world would not be knowing Peter Giannoudis. Anybody who is interested in trauma, who has been learning about trauma from the world literature, as well as from the various books, would have read at least 10 articles of his on some topic or the other till now. That's his introduction. I would say he has got lots of things under his kitty, but it's really our honor to have Dr. Peter Giannoudis with us in this tibial plateau fractures grand round. Then we have Dr. Sanjeev Anand, who is a consultant knee surgeon at Leeds Teaching Hospital. Again, a leading expert in the soft tissue reconstruction and the bony procedures of the knee. He was working in Delhi for some time, and then he has gone offshore and has given his expertise in United Kingdom for the last many years. And many of us have been seeing him, though, in our televisions every day. Dr. Sanjeev Anand. Then I have the pleasure of introducing Dr. Mukesh Jain, one of our mentors and my mentors, I can say, who is the director and a senior orthopedic surgeon from Muzaffarnagar Vardhaman Hospital, who has literally built up the trauma setup as well as the advancements in trauma in the northern India, and has been a leading light of trauma surgery across the India as well as in the world, based on his AO expertise as well as his AO experience worldwide. Dr. Mukesh Jain, please. Then we have Dr. Pushkar Chawala, another bright and young, one of the first FNBs in specializing in trauma surgery from India, who is now a senior consultant and a trauma team from Indian Spinal Injury Center, which is a big center again in New Delhi, India. And he, along with one of his teammates, has been doing wonderful work in trauma surgery for the last many years. It gives me great pleasure to introduce one of my colleagues, Dr. Samartha Mittal, whom I had the pleasure of teaching sometime, but now with colleague, he is my colleague, and we are really blessed to have him in our trauma team. He is an assistant professor, one of the brightest stars in trauma team in India right now, and he's working in trauma center at our AIIMS, New Delhi, Dr. Samartha Mittal. And myself, I'm Vivek Trikha, working as a professor at the AIIMS Trauma Center, New Delhi. Now I would stop the screening and I would like to start the ball rolling by inviting Dr. Peter Giannoudis for his talk and for his case discussion on one of the complex cases which we would like to present. Peter, can you share your screen, please? Thank you.
Thank you so much for the introduction, for the invitation. It's a great pleasure to contribute to your educational events, which I'm aware they are to the highest standard. So we are talking about tibial plateau fractures. To start with, I would like to submit to you what I think is very important for any fracture that we are considering to reconstruct. Any fracture which goes through the joint, we need to aim for anatomic articular reduction. We need to restore the mechanical axis. We need to ensure that our fixation will be stable enough to allow limb mobilization, not just of the injured joint, but also of the adjacent joints, and also to optimize the recovery of the patient. And this applies for all fractures, for all methods of treatment. When we talk about tibial plateau fractures, I would like to remind to all of you that we need to consider the patient as a whole. Every patient is different, every fracture is different. We need to evaluate carefully the state of the soft tissues because these will dictate the ideal timing of intervention. We need to aim for joint congruity, anatomical reconstruction of the affected articular segment. This is very important to minimize the risk of post-traumatic osteoarthritis. And also we need to think of potentially other associated injuries, which can be in the tibial plateau we are planning to reconstruct. And usually you need to think about injuries to the soft tissues, to the ligaments, which is very, very important. So this is a representation of what we are trying to achieve. This is my favorite chocolate. And that will demonstrate the point. So you've got here a tibial plateau fracture. This is a hyaline cartilage. This is the cancellous bone. And what happens is when you've got an injury, then you've got this depressed intra-articular fragment. And as a result of the impact and the depression, you get the so-called compressed metaphyseal bone, as you can see here. And that means that because of this displacement, this impaction that takes place, and this compression of the metaphyseal area, we need to elevate the depressed interarticular fragment, as you can see here. But then when you do that, because of the compressed metaphyseal segment, then you are being left with a bone void, as you can see here. So we need to think about this void, how we are going to augment the bone there so that our anatomical reduction that will be achieved will be maintained, and we are not going to have secondary loss of our reduction. Now, I don't know whether you have seen this book, but I would like to share with you the chapter that I contributed, Variables and Factors that Influence Patient Outcomes Following Tibial Plateau Fracture Fixation. And you can see the factors that they can negatively affect the overall prognosis is medial plateau involvement, articular step-off greater than 4 millimeters, and higher numerical Chaske classification type. Now, let's move on to a case that I would like to share with you. This refers to a female patient, 58 years of age. You can see here the original radiographs. She fell having stepped into a pothole. And you can see on the CT scan, always we need a CT scan evaluation of the injury, because that will allow us to clearly define the area of the damage. And you can see here the area of the impaction. You can utilize your software to evaluate the length of the depressed area, but also the amount of depression. And you can see in this case is almost 2 centimeters. So there are different ways to approach this injury. Today, I would like to share with you a minimally invasive approach that I often use in my unit, in my institution. And this minimally invasive approach refers to the utilization of the kypho set that maybe you are familiar to utilize it when you do spinal surgery, but it can also be utilized in trauma cases, and particularly in tibial plateau fracture cases. So you must have the kypho set. Also, you must have Omnipaque, a dye that will allow you to visualize the application of the balloon during surgery. So these are the intraoperative pictures. You can see the fluoroscopic image, the area of depression of the lateral tibial plateau. You can see here the extent of depression on the lateral view. And when we want to apply this technique, you need to go into the medial side of the patient, and you need to mark the level of depression. And this is very, very important, because this is where you will have to go in order to be able to elevate the depressed articular segment. So you can see here the medial side of the patient. You can see the bolster. So I mark where is the depressed articular segment. It's here, and then I make a mark on the medial side of the opposite side from where is the injury. And then the next step, utilizing this technique, is to make a small incision over the lateral side and to slide the plate you are going to use, as you can see here, do a kind of a dissection to slide, like a tunnel, to slide the plate underneath the soft tissues over the anterior compartment. And you can see that you apply the plate and you stabilize it with a K-wire to start with, and distally as well. And this is very important because you need to support the lateral wall of the tibial plateau. There is always a small fragment which goes through the cortex. So unless you do that, when you will bring the balloon to inflate and elevate the depressed segment, what's going to happen is you will push the lateral wall away and you will create a bigger problem. So you put the wire, but then as you can see, you bring your reduction forceps over a small stab incision from the medial plateau side and over the plate, so that you can support well the lateral column of the tibial plateau. And then from where you marked on the medial side, you make another small stab incision and you insert the trocar under direct fluoroscopic vision, and normally you push the trocar underneath the area where is the impacted articular segment below the level of depression. And then when you do that, as you can see now, through the trocar that you made your pathway, You bring your cannula, and through this cannula, as you can see, you insert the balloon. Here is the balloon underneath the area that you want to elevate. And when you are happy with the positioning on the AP and lateral view, and you can see how I maintain the integrity of the lateral wall of the tibial plateau by utilizing my reduction forceps, supporting the lateral wall with the plates, as you can see in this intraoperative view. And then you start inflating the balloon, okay? And what happens is, because it's underneath the area of the depression, as you can see in the next view, I can continue to inflate the balloon, and eventually I can get anatomical reduction of the impacted area, as you visualize in these sequential fluoroscopic views. On the lateral view as well, you check and you ensure that you have elevated completely the articular surface. In some cases, if you've got quite extended area of depression, then you may have to consider to use two balloons so that you can elevate the depressed area, even if it's quite extended from anterior to posterior or even from lateral to medial. And again, that's just demonstrating the anatomical reduction by the inflation of the balloon. And then when you have inflated the balloon and when you have reduced the anatomical, the depressed articular segment, you need to stabilize it with K wires, as you can see here, so that then you can deflate the balloon. But when you deflate the balloon, because the K wire will maintain your reduction, you are not going to allow that elevated depressed segment to shift downwards and lose the reduction. So you can see here my K wire through the lateral side now that is supporting the segment that I elevated. And when you deflate the balloon, you can appreciate the void that has been created in the subchondral area of the zone of the injury. And of course, what we need to do then is to ensure that there will be some form of bone substitute in here, which will fill the gap and will support the previously depressed articular area so that it will not going to be any secondary collapse of your reduction. And at the same time, by injecting here through the cannula, again, you can see the cement that is being injected into these voids. Then through the plate, you can also insert some screws through the cement, which means that you will have a very good technique to support the reduced articular surface. So you inject the cement into the void, as you can see here. All that void now is being filled with a bone substitute. And like that, you reconstitute the amount of bone that was missing from there. We all know that the bone cement has very good compressive properties so that will withstand any kind of axial loading or torsional forces during the subsequent rehabilitation of the patient. And you can see here now how you can proceed with completion of the fixation of this injury by insertion of the screws into the plate that I used in a rafting mode so that you can complete the reconstruction of this injury. And these are the final views after fixation, as you can see, the fluoroscopic views, how we managed to optimize the reduction, maintenance of the reduction and fixation of this injury with this minimal invasive approach that I shared with you. So I would like to stop here now I will stop sharing my screen as well and take some questions if there are any.
Okay, so thanks, Peter, for that wonderful case and a new thing which we. Thanks for that wonderful case and the new technique which we learned. There are a few questions. Dr. Mukesh, you are having one question right now?
Yeah, Peter, I have two questions. The first question is that for how many days you can wait? Because most of the time we get these patients after 10 days, 15 days for surgery. Is it possible to do ballooning at that time? Number one. Number two, if there is an entrapment of the meniscus, how you decide whether to go with ballooning or to go open?
Yes. So these are very good points. With the timing of intervention, I have used it up to 2 weeks after the injury, and I didn't have any problems. If I believe there is a problem, then what I do is, from the medial side, I approach the elevated area with a traphawan, and I try to mobilize it a bit to create a level where the balloon then can start elevating the segment. So decompress it a bit and create some kind of a zone where I'm going to bring my balloon so that when I will start inflating it, will start elevating that segment. So you can do that as well. There are different, ways to get around that kind of a delayed timing of presentation of these cases. In terms of the meniscus, this is a very good point. It's always difficult to know whether the meniscus has an injury or not. So a lot of people take the view that if it's a problem, I would like to know at the time and address it. So you can do a submeniscal arthrotomy to evaluate it, or even you can, in this case, it might be a good case also to do an arthroscopic assessment, because you don't have a very big injury to compromise your arthroscopic assessment in terms of having, a Shaska 6 where you can start losing a bit of the fluid. There is a risk of compartment and so on. In my practice, if I have a very uncomplicated elevation without any problems, then I don't look routinely in the meniscus. I EUA the knee, and if it's normal, then I don't do anything else. If I have an issue and the reduction is not straightforward, then that implies, or some of my omnipaque, some of my cement, or sometimes the balloon can burst. If that goes a lot into the joint, so that's a concern, and then I would, following the reconstruction, I would do also a mini incision to look into the joint and ensure that the meniscus is not affected. But over the years, whenever I followed this approach, if I have no problems with reduction, I never had to go back to address a problem with the meniscus.
Thank you.
Thanks for that answer. And I have two questions right now with me from the audience and the delegates as well. Peter, why do you use bone cement rather than some injectable bone substitute which can aid in healing, rather than a bone cement which can cause some heat effect and cause damage to the cartilage? And the second question is putting in by one of our faculty that when you are putting in a plate before and compressing it with a C-clamp, sort of a clamp, then isn't a trapdoor effect having, and then the elevation may not be appropriate?
Yes. Again, these are two very good points. The first point, maybe I didn't make myself clear. I said a bone substitute, and also this hydrocide, whatever we inject, is a kind of a cement, not PMMA cement.
Okay.
Right. So it is a bone substitute.
Right.
That's what I use. I never use PMMA cement.
Okay.
It is not indicated in these kind of cases, and I've never used it in any kind of reconstruction that I do that relates to a subchondral void.
Right.
Okay, so that's a no utilization. Right. So we are all in agreement with that.
Yeah, sure.
In terms of the reduction clamp, I secure it just to keep the blade aligned with the wall. I don't put any pressure to create that trapdoor effect and not to allow the depressed segment to be elevated. So it's just enough pressure to maintain the lateral wall. And if I see there is an issue with when the balloon is inflated and I don't see the elevation I expect to see, I release it and I just maintain the overall alignment without any pressure at all. So this is a very good point and it's very important for the technique, but you just need to align it without any pressure to bring it across. You will do that when the fragment is elevated, then you put some pressure to bring the plate across, but you need something to minimize the risk of the lateral wall being exploited because of the inflation of the balloon.
Right. So I think that's a very two good points which you have brought out, that should not be putting in a clamp which is too compressing the thing so that the trapdoor does not happen, and the plate is acting as a lateral wall so that any defects out there can be taken care while you are putting and inflating the balloon out at that time. One more question, just for the sake because it has been coming right from the beginning to us from the delegates. Do you prescribe for an MRI in any case of proximal tibia right in the beginning? It's not related to your case, but as a general thing, what do you do? And is MRI a primary investigative tool?
Yeah, I don't use it routinely in my practice. If there was a fracture dislocation, then definitely yes. But not routinely in these simple cases, in my opinion. I don't use MRI.
Right. What about the other faculty? Can you just give you, Dr. Mukesh?
Yes, you see, nowadays to convince the patient, many times you need both of things. You need the CT scan also, you need MRI also. But for me, mostly there, especially for whenever I feel that there might be some meniscus injury, then my MRI is indicated. And especially in medial condyle, when I have the combination on the lateral side also posteriorly, those cases are always the entrapment of the meniscus. That is number 2. And third, all complicated cases, all complicated trauma, I go for MRI.
Okay. Dr. Sanjeev, I think you also for the fracture dislocations? Or
definitely, as Pete mentioned, from fracture dislocations, yes, definitely. And as Mukesh mentioned, the medial plateau fracture, with when I'm suspecting lateral side injury, some of them are apparent when there's a fibula avulsion. You can obviously see that fibula is pulled off, there will be lateral injury. Some may not be that apparent. And some of them, when they come with a foot drop, definitely, because there would be a lateral injury. So you want to get that. Standard anterolateral tibial plateau just for meniscus as a routine, I don't. Because my approach is open approach. I do some meniscal arthrotomy and repair meniscus as required. So for those, I don't.
Okay. Dr. Samartha, what's your experience of doing an MRI in acute cases, and what has been the reaction of the radiologist, or what do you face any problems while doing that in an acute phase?
Thank you for asking me that question, sir. Sir, as you're aware that in the center that we are working in, trauma center, it is difficult to get an MRI done in the initial few days immediately following the injury. So as a protocol, the radiologists at our center do not allow us to get an MRI done within the first 2 to 3 weeks of the injury, because there is a lot of artifact and it is very difficult to interpret these MRI scans. So, and a lot of these MRI scans show a lot more things than there usually are, and they do not correlate very well clinically when we go in. But then this paves way for my talk that for my case that is coming up, where yes, these are situations where after discussing with you, then we discuss with the radiologist, and then they are very happy to do MRI scan for our patients even on day 1 as well.
Yeah. So that's for the prelude to the next case which we are going to have from Dr. Samartha Mittal. But just one parting shot from Dr. Sanjeev. Do you have faced any problems, and what exactly are you looking for when you get an acute MRI in the first 2 or 3 days?
When you say facing problems, getting an MRI done, yeah, I mean, we work in a public sector as well, National Health Service. So yes, it can be difficult. Sometimes getting MRI done acutely, which can delay treatment occasionally, and it's a big problem for us. Because lots of our patients come as a referral from other institutes, so they come to us around anywhere 7 to 10 days later. And then you're trying to arrange MRI, and then the fracture almost starts to consolidate. So yeah, it is a problem. I guess you have to persist and talk to others, as Samartha mentioned. But they do understand, especially if somebody senior goes and talks to them, they do that. In private sector, I guess it's not a problem. What was the second part question?
Regarding the artifact situation in the acute setting, do you face any problems, and do you take care of all the defects which you see in the MRI at that time?
So look, no, MR obviously shows lots of things, and lots of these patients, when they come to us, they have an external fixator applied as beforehand as a kind of soft tissue kind of stabilization strategy. So yes, there are artifacts, but you know what you're looking for, and you go with a specific question in mind. And if you go with specific question, that's the answer you usually do get. But then after fixation, examination under anesthesia is actually the key really. It's not just MRI. After you fix, you do a EUA, then only you make a decision whether you need to do ligament reconstructions or not.
Yeah, so that's the point which was very well brought out by you, that you go specifically looking for a particular point which you want to see and ascertain in an MRI, rather than just prescribing an MRI just for the sake of doing one more investigation for the patient. You look for a specific point, see whether it is there or not, and then confirm it intraoperatively or after fixation to look for the stability part. So with that, I would go on to Dr. Samartha Mittal and ask him to present his case.
Thank you, sir. I thank DOA for giving me this opportunity. I cannot thank Dr. Vivek Trikha enough, not just for inviting me here, but for being my guru, my mentor, and all that I know in the trauma practice that I do at Trauma Center AIMS. He's been my source of light for all sorts of trauma. So today I'm going to present a case on anteromedial tibial plateau fracture. So this is a 23-year-old male who's a basketball player. He's a college student and plays fairly well. He plays for the state team in Delhi and plans to go for the national team. And he sustained a road traffic accident while riding a motorcycle. So he was riding a motorcycle and he was hit by a car, and he suffered an injury to the right knee. And he presented to us in the emergency department on the day of the injury itself. So when we clinically examined the patient, he had a swollen right knee and he had pain and restriction of movement in his right knee. There was no distal neurovascular deficit, no foot drop or any vascular deficit, and he had no other associated injuries anywhere else in the body. So he was sent for X-rays, and that's his first X-ray that we got. That is the anterior posterior view of the knee that we got, and which looked almost all right to us, but as a rule, all X-rays should be done in at least 2 views. So that's the lateral view that we got, and it had a faint shadow on the anterior part of the anterior tibial plateau. So if you see, the anterior tibial plateau shape is slightly distorted, and this is the time then when we got a CT scan done in the emergency department itself, which revealed this fracture on the 3D recon as well as the 2D sections, which shows a very small anteromedial rim fracture on the anteromedial proximal tibia. And those are the 2D cuts. So compared to what we saw on the 3D sections, which showed only a cortical shell of bone on the anterior rim, on the CT scans, 2D scans, it's quite clearly visible that this on the tibial plateau goes up to almost the center of the tibial plateau. So it's almost 50% of the anterior tibial plateau, and it has led to depression of the anteromedial tibial plateau surface, leading to reverse of slope of the tibial plateau as well. So I think most of us would agree that this does not need a conservative treatment, but does it need any other evaluation?
Yeah. So, Dr. Mukesh, in your experience, how many times you have seen this pattern of fracture, and what is your further investigation, if any, for this?
See, many times. These injuries are very common nowadays. almost
has it increased?
I get one hyperextension injuries.
Yeah, yeah.
And these injuries, yes, definitely they need a proper CT scan to visualize each and everything. And at times, MRI also is needed for these injuries.
Dr. Peter,
Mm-hmm.
what's your experience and how many, if I can say percentage-wise in your practice, how many cases do you see of this pattern of a hyperextension, and in which age group that you are seeing this?
Yeah, again, we see it maybe in 20% of the cases. We see it in young patient groups.
Mm-hmm.
You need to be aware of the fragmentation, the impaction, the fact that is not a very routine fracture that you just put a plate and you fix it. You need to think about it, how you will maintain the articular congruity and also the stability of the joint. Mm-hmm. So it's more common than we used to see in the past. And yes, it's. I'm sure everyone in his practice will have seen these sort of injuries.
Yeah. You can go ahead.
So, like everyone says that these need to be operated, these cannot be conserved, and like we discussed before, so there is not a lot of literature on these injuries, even though we all seem to have seen this injury a lot now. So there is some amount of data on hyperextension injuries, but most of them are bicondylar fractures. So on isolated medial condylar fractures with an anterior rim fracture, the amount of literature is not much out there. And but there are mainly two mechanisms of action that we found were causing these injuries. So coming to these papers, so this is one of the biggest papers from Dr. Firozabadi from Seattle, which was published in JOT in 2016, wherein they've presented their cases of hyperextension injuries, which most are bicondylar types. But the fracture fragment and the size of the fragments here is not that small, and the anteromedial tibial plateau fragment is fairly large to accommodate a decent sized plate and to buttress it. And then this is a recent paper published in Injury in 2020, wherein they have shown their experience from Spain, in Barcelona in Spain, of hyperextension bicondylar tibial plateau fractures. But there is very little on isolated anteromedial tibial plateau rim fractures, and this is one of the papers that was published recently in 2020, wherein they say these are diagonal lesions. So in addition to a anteromedial tibial plateau fracture, one has to have a strong suspect of a posterolateral corner injury. And they have defined that these fractures can be of two types. One can be the small anteromedial rim fragment, which is less than 25% of the medial tibial plateau, and the other type is more than 25% of the medial tibial plateau, which is figure C from there. These photos are from their paper, and which have a slightly different presentation from the one at the top. And there is another school of thought from one of the papers from a single injury, which says that these injuries can also be caused by a flexion injury, wherein the anteromedial part of the tibial plateau along with the MCL attachment has just come off as an avulsion fracture rather than being a compression fracture. So, and most of these papers are in form of case series, not a large amount of literature on this. So going by these papers, we were able to convince I discussed with Professor Trikha, and we were able to convince our radiologist to do a MRI scan, thinking of a posterolateral corner injury or a LCL injury here. But to our surprise, there was no posterolateral corner injury or PCL injury, but in fact, there was an extruded medial meniscus in this case. So, and then when we read the literature, we found isolated cases, 2 or 3 cases wherein people have reported these injuries to occur, even though people had thought earlier that these injuries cannot occur without a significant damage to the posterolateral corner or the PCL. But then there are now case reports which say that these injuries can also occur without PCL injuries and PLC injuries, especially in people who have hyperlax ligaments, wherein the ligaments do not break, but they just elongate and cause compression on the anteromedial fragment and cause this fracture. So conventional thinking is there is some soft tissue injury at the back, but there might not be, and you might see extruded medial meniscus. And these are patients wherein MRI is probably a good indication to be done in the acute phase in these fractures. So, as we know, and the anteromedial part of the tibial plateau will have the deep fibers of the MCL, especially the meniscotibial fibers. And in operating upon these fractures, there is usually not an MCL injury, but while operating these, due to dissection, one can cause an MCL injury. So that is one aspect which needs to be taken care of. So when we went into this case, so after lifting up the fragment, if you saw on the preoperative scan, the size of the fragment is really small. It is less than 5 millimeters. And compared to all the other papers that have published these, the size of the fragments in our case was really small, and we did not think the conventional plates could have fit in for this. So out of the box thinking, we used the compact handset and used some of the hand plates, a T buttress plate, and we just elevated the fragments with the osteotome, put in these plates and fired subchondral screw into the joints just below the joint surface. And just to give it more stability, we used a 3.5 slightly more rigid plate, Ali's distal radius Ali's plate, as a pure buttress plate, just to add on to the stability of the anteromedial fragment. And then we did a intraoperatively hyperextension just to check for the stability of our fixation. This patient was operated 2.5 years back. That is his X-ray 3 months down the line in July 2018, which seems to be healing well, and with the tibial slope corrected. And that's his 2.5 years follow-up, wherein he seems to have had a good joint line, well maintained, with a good tibial plateau slope. And those are his 2.5 year follow-up with his good knee flexion, good knee extension. You can even see the scar on the right leg there. And that's his knee flexion. He can sit on the ground. He has continued to play his basketball, and he doesn't have any limitations with that at present. And that's a video of him moving his knee in full flexion and knee extension. And he says, I don't have a problem jumping in basketball at all. So I have, if you allow me 1 more minute, I have 2 more such cases. So
you can show that.
Another
you can just go through them so that we can discuss them in the.
So 18-year-old male showing a similar fracture. The AP view in these are usually seem to be absolutely fine. It is very difficult to find a fracture on the AP view. And if you look at the traditional Schatzker classification, we may not be able to classify these fractures at all according to the Schatzker classification. So the lateral view gives you some doubt, but then the CT scan usually brings in what we need to see. And then these are the CT scans of this patient. Again, a very small anteromedial fragment. And I went in with the same compact handset, discussed with Dr. Vivek Trikha. Our team went in, and again we saw these fragments were really small. So in this case, instead of using a 2.5 2 plate, we used a 2.5 foot plate, contoured it according to the anterior proximal medial tibia. This is actually meant for the midfoot, this plate, and it worked wonderfully well for this case, wherein we got good elevation and good restoration of joint line on both AP and lateral views. Another female that we had was a 37-year-old female, and this was a hyperlax female that we had. So according to some papers, this may not have a posterior lateral corner injury or a PCL injury, but on a CT scan, this patient had a posterior medial tibial plateau fracture, anteromedial tibial plateau fracture, as well as a LCL avulsion from the fibular head, a bony avulsion of the fibular head. And that's how we went in. So we went in through a medial approach, fixed in the posterior medial tibial plateau. The anteromedial fragments were really small and crumbling. So what we did, like Professor Giannoudis explained in his presentation, so we first used a plate, the same foot plate, and we used it as a buttress plate just to contain the defect on the anteromedial side. After we contained that defect, then you can see that small screwdriver we used through the plate to lift up all the fragments, while we did a submeniscal arthrotomy to look at all the lifted up fragments. And once all the fragments were lifted up with the anterior wall intact, to prevent its blowout, we added some artificial bone graft just under this. And then to end the procedure, there was a big bony chunk of the LCL, which was avulsed from the fibular head, and then we fixed it percutaneously with a cancellous cannulated screw. Those are the immediate post-operative X-ray of this female. So I would like to conclude the case by saying that atypical marginal rim fractures are very rare, and they're rarely described fractures of proximal tibia, although with so much of experience among all the faculty, almost all of us have seen these fractures. So like we already pointed out from the last discussion, that careful evaluation under anesthesia is very, very important in ruling out all ligamentous injuries. So as a rule, whenever we fix any proximal tibia fractures, after fixation, we do a careful EUA to see if there are any associated ligamentous injuries. Probably these are the patients where a preoperative MRI makes sense. And if there is extruded medial meniscus or torn ligaments, then this is the time then we can fix these patients at the same time. And fragment specific plate fixation, and to keep all the options open for a small plate and other plates is something that is advisable for these cases. Thank you.
Okay. Right, Dr. Samartha, for that great presentation. Dr. Pushkar, what is your experience of dealing with such fractures, and how you have been able to, what further or any further thing which you do for such fractures, just besides the plate fixation?
In my experience, in our experience, I can say, we have not very routinely sees these patients. These are majority time younger patient, if I say, than the elderlies. In my experience, majority of them are associated with the others fractures also, like in the type the Dr. Samartha has shown the third case. The fracture like these are common, where we need to assess them anteriorly also to do some kind of a support. So from the routine teaching, from the bigger plates to smaller plates, and then now the additional hand and foot plates. So we have to keep them in hand or keep it in handy to deal all these patients, because these fractures sometimes may not be visible on X-ray. So you have to have the CT scan very clearly seen beforehand to arrange all these sets beforehand. It's sometimes may be difficult. True. Sometimes you may catch inside the OT and find out, oh, this is really small. Like why can't I hold it now?
Right. Yeah, Dr. Sanjeev, just one query with you. Would you like to say right now regarding this fracture, or maybe after your case that you would like to elaborate?
I might say, I think Samartha, it was really brilliant set of cases, and I do see these cases often. And I think Samartha brought about this concept of rim plate fixation really well. And the fracture pattern usually, because the medial subchondral bone is actually quite dense, but as the fracture, the hyperextension forces goes down, the femur goes down the tibia, medial tibial plateau goes down, but the outside shell, the outer cortex, that's not that strong. That kind of explodes out. And when you reduce it, you find there's a really thin shell. And then sometimes as you start to fix it, you find there's not much bone. Even when you try to put screws, there's not much bone. So the rim plate is good. But what my approach often for these is, because I worry about the secondary collapse, I put a kind of a structural graft over there. So I put a wedge just because I don't want the plateau height or a secondary collapse later, and then do a fixation with that. But you're a good set of cases.
That's a great point. That yes, I was just going to bring out that fact that can we have a wedge which can be put in, because that's like an osteotomy. When you lift that up, it's just like an osteotomy which has been done in the anterior medial part of your tibial condyle. Yeah, Dr. Pradeep has raised his hand. May I have his question, please? Yeah.
Hi, Dr. Trikha. I just want to concern is one question. It's a very marginal rim fractures. Considering we are not trained and some setups we can't operate, and what is the implication? What is the complication we see if we leave this fracture for 4 weeks?
So, Dr. Peter, would you like to answer this question about the rim plates and the rim fractures, which we nowadays are seeing quite often, both on the lateral and the medial side? So, if they're very small, what is going to happen if we leave them conservatively?
Well, it's always a fine balance between fixing them and not fixing them. I think if there is a lot of comminution, still you try to just contain it. Otherwise, you cannot immobilize completely the patient for a period of time. So still, I think you need to work around minimal disruption to the soft tissues. And I think what Sanjeev highlighted, some form of graft to give you some extra support, is the ideal case scenario to consider in your practice. Mm-hmm. You can use also some fibrin glue sometimes in between. I've done this to just maintain the fragments together. And that gives you some kind of a block, although it's fragmented, but you can just go around it with a rim plate and just support it. And I think that will provide some form of, let's say, maintaining that kind of lateral limb without displacing further. So it's if it's of course a very trivial injury and it's like too many small fragments, that's a bit more difficult. In that case, what I've done in one of the cases, I've used a collagen sponge with tricalcium phosphate to put it around and then put it over it the plates to contain it. Maybe next time I will show you this case.
Yeah, right. Yeah, that would be great to see some new innovations which you are doing for these sort of fixations and fractures.
Thank you.
Yeah. Thank you, Dr. Pradeep, for that question. Dr. Mukesh, any tips in your kitty that how to use and fix those rim fractures, and any plates which you are going to design or have already designed for these?
I think Samartha has already told you about the plates, like you can use the hand plates, you can use the wrist plates also. The only important thing I would like to add that these fractures can be treated very well with the help of the distractor. You distract on the medial side and then do the open surgery, and then you can lift the meniscus and then you can see the cartilage, you can see the whole bone very well. And once you align them, once you reduce them, again, there is a difficulty in reducing them, holding them. For that, you can use 2-3 K wires together, and then you can lift the fragment to the right position. And after that, tricortical graft is very important to support it. And once you support it, then you have to put many plates, not one. You have to put plates on the medial side, you have to put plates anteriorly. At times, you have to put 3-4 plates of the lower end radius, so that you make a complete circle all around the medial side, so that there is no chance of collapse. That is the only thing I would like to add.
Okay, fine. So after looking at these two specific case patterns, new case patterns, I would say, a new innovation by Peter and by Dr. Samartha, the new anteromedial fractures which we are seeing nowadays, we come back to the most common fracture which we see in proximal tibia in India, especially the complex fractures. And none other than Dr. Mukesh Jain to present his case of a complex fracture and bring out the salient features.
Sure. This is my new setup for last 1 year. And this case is one of the most difficult cases I had in last few years. This patient came to me almost after 3-4 days of the injury. He had a marked swelling, there were superficial blisters, and there was no compartmental syndrome. Now you can see that how complicated it is, that I have never seen this type of the fracture. Now, the first question to me is that when patient comes to you, can we reduce it? Should we reduce it? Dr. Trikha?
Yeah, can I ask few people, faculty, because your case will we have to discuss at every point. I think that very common fracture pattern and many questions have already come for such a pattern. So may I start with Dr. Pushkar, that how exactly are you treating this when this comes to you? Are you putting in a fixator, traction, or what? Anything?
Because considering the injury, considering the fracture pattern, it shows it's a high energy local injury. So soft tissues will longer time and if I put a fixator, it's just aligned. It helps in reducing the swelling. It helps in getting my alignment right at least. It also helps in intraoperative reduction also during my fracture fixations. So I will try to fix first external fixator, then wait for my soft tissue to settle down and do a CT scan and then
further we'll discuss those things. So right now it was
this is an ideal case for what we call damage control. Yeah.
Right. So Sanjeev, can I ask you regarding this, that there was one question from the delegates as well. What sort of fixator do you use if you are using for such fractures? And is it necessary to put in the shank pin and put in a joint spanning big one, or just there are some indigenized way, as you might be knowing in India, putting in a Steinman pin into the distal femur and in the distal tibia and just distracting them. Some people just put in a lower tibial traction and just keep it. So there's a lot of queries which I have got from the delegates right now. Which fixator and any particular usage and indication for them?
Okay, you can hear me now?
Yeah.
Okay, I'm afraid I don't have much experience right now for traction in bed. Our practice is very much fixator across knee, across the joint fixator. Of course, it's important to stay away from the zone of injury when you start putting pins. It's kind of, essentially it's a uniplanar fixator, but people sometimes put pins right in the front of the femur through the quads, because they cause a lot of scarring and stiffness.
Mm-hmm. Is it?
Should I go ahead?
Yeah. I think we have lost Sanjeev for some time, so maybe Dr. Mukesh, you can continue with the same.
So when I saw this fracture, I was in dilemma and I thought I'm smart enough that I can reduce this lateral condyle into the articular surface. So I just thought to put a distractor on both sides. One distractor on the medial side to hold it so that I make a hinge. And on the lateral side, I started distracting, thinking that I will be able to push this fragment in. But somehow I could not do. I was not successful. Then I left it on simple fixator.
Just one question right now.
Sure.
Sanjeev or Peter, can you answer that? Would you have gone here? Many times we also feel and face this query that should we open up the fracture right now with a minimal incision and try to reduce it, or leave it as such and just keep the traction and the distraction and come later on and tackle the fractures anatomically?
Yeah, the key issue is to get this early and put the X-fix the first 24 hours, because then with the recommended axis you'll be able to obtain a better kind of overall alignment in all planes. And sometimes because of the degree of impaction, even if it's early, you might not be able to actually get it out to length and disimpact the fragments, and as you would have thought to be otherwise. In that case scenario, I think from the theoretical point of view, it would make sense. Well, can we do a small incision? Can we do this and that? What I do personally is I utilize some K-wires, and I try with the K-wires as a joystick to improve the segments without compromising the state of the soft tissues. And I found this very, very helpful over the years, at least to disimpact them, elevate them, and then distract the joint in such a way which will help with the resuscitation of the soft tissues. We know that these high energy injuries probably will take 10 days, 2 weeks to get to them. So even if you make with the K-wire small pricks through the skin, by the time you will go in, will have healed.
Thank you.
Yeah, continue. You can continue.
So after 10 days after putting the fixator, we went for the CT scan. And now you can see the 3D pictures of, this is the anterior view, where you can see that there is a coronal fracture, which you can appreciate. And then there is a comminution in the medial condyle also. And then there is a huge anterior tibial tuberosity fragment. And then there is the complete articular surface with a little part of the metaphyseal bone is in the lateral gutter. So this is the anterior tuberosity, this is the anterior part of the medial condyle, and this is the posterior part of the condyle, and this is the comminution. And this is the totally lateral condyle which has come out into the lateral gutter. Now if you see the posterior view, there was another piece which was the metaphyseal piece from posterolateral part of the tibia, just behind the fibula, and there was a huge vacuum on the posterior side. There was no support on the posterior side at all. So this is a lateral condyle articular fragment. You can see this is the whole of the articular surface and little bit of the metaphysis attached to this subcondylar bone. This is in the coronal plane, you have this medial condyle coronal plane fracture. So my problems were Number one, there was a medial column fracture, which has a coronal fracture. Then we have a medial metaphysis combination, the anterior tuberosity fragment, the lateral condyle articular fragment, which was lying in the lateral gutter, and a big posterior lateral metaphyseal displacement fragment. And the whole tibial condyle to be aligned with the diaphysis. So we have all these 4 or 5 components. So we have to bring each other together and then fix the tibia. So I decided prone position. And this prone position, I thought because there was a lot of combination. Okay. So I thought I would go with a bigger incision so that I can take care of the lateral side also. And this is after reduction, I put these 2 plates. One was holding the medial border, other was buttressing the coronal fracture. Now, with this, I could get this much of fixation. The coronal plane, you can see that medial condyle is completely aligned. And then we could support with the buttressing plate because there was huge bone void. So it was not possible to take out any screw into this region. So I put a longer plate holding here and holding into the diaphysis. And then I support it on the medial side also, so that I have a perfect alignment of the medial condyle to the diaphysis. So medial pillar is ready. Now, if you see this is now in supine position, it looks pretty good. Now, in supine position, again, the anterior lateral approach. Now you can see the whole tuberosity fragment. So this was good for me to see inside because there was a huge vacuum. And this was the lateral condyle fragment. Now, if you can see that the whole of the meniscus is lying as such, there is no injury, but it is loose. So I just put this whole of the condyle and I try to align with the meniscus and to the medial condyle. And then I put 1 or 2 K wires. I could get a pretty good alignment here. It's not perfect, but it's okay. And then I put this tibial anterior tuberosity fixed with this lag screw here. So now it looks a complete good alignment. And then because there was a huge piece on the posterior lateral side that I compressed it and then I put a K wire just to hold it. And then I put this plate. So this is the wire which is holding to the posterior lateral fragment. This is holding the tuberosity. And now I applied a plate, lateral condyle plate. I kept in my mind that I should have a good drafting plate over here. So I can take 4 or 5 screws to support this fragment. And this is immediate post-operative. This is post-operative after 2 months. Still, I was a little worried that either it can go to AVN or it can be depressed further, but it is still maintaining after 2 months. And this is after 3 months. And I just supported this plate also, the tuberosity, so that it buttress also. So I have taken a very small plate here, a very small plate here, a very small plate here. Only this plate is a little stronger on the lateral side. So total amount of the plates, they are very thin plates, very weak plates. And this is after 5 months, still maintaining everything as such. This has also united and the whole of the fracture has united completely. And now this is the clinical picture after 5 months. There is a lack of extension a little bit, but you can see this incision very well. And this the patient is standing, and this is this incision which you made the Leo incision. He's able to walk, but with the help of a stick at the moment. I just saw him 3 days back. He can walk only with a stick. Otherwise, he's perfect. He doesn't have any pain. So take-home message is it's a highly complex fracture. They need full understanding of the fracture. 3D pics are very important rather than 2D pictures. Every condyle needs a separate fixation and buttressing. Make medial condyle first and connect to diaphysis. May need 1 or 2 weak plates. Never use the stronger plates here because they can damage to the soft tissue. And the lateral condyle needs a separate plate, and tibial tuberosity needs a separate buttressing plate. The intra-articular reconstruction and stability, these 2 things are very important, and they can give you good results, which you have seen in this complicated case. Thank you.
Right, Dr. Mukesh. We expected nothing less than this from you. So
thank you
that's
so much.
The first thing. It's a case which will give nightmares to every trauma surgeon when he gets here. I would just like to start, and this is a huge, I think there will be a lot of discussion from all the faculty. So I would like to start by saying that what would have happened if you said there were some blisters out there, but let's say that the blisters were hemorrhagic and it were circumferentially out there with such a devastating soft tissue injuries and the bony injuries. Then what would have been your protocol? And what about, let's say, compartment syndrome and the releases which may be 6? How do we amalgamate our fixation with the compartments? And that will come to, I think, all the faculty one after the other, starting with Mukesh.
I think there are three different components. The one is the blisters part. They were superficial in this particular case, and I already kept him on a fixator for 10 days. So that was taken care of. The skin condition was very good. But your second question is, if the blisters were hemorrhagic? Yes. If the tissue was not healing in 15-20 days, probably it was a difficult job for me. In that particular case, probably I could have considered a hybrid fixator rather than going for these plates. I could have made a small opening to reduce the lateral condyle and take the help of the hybrid fixator. And if there was a situation, what you said about what you said, the third question was?
Regarding the soft compartment release and fixation.
Syndrome, that you have to consider on day one. You have to go for fasciotomies and whatever the minimal fixation you can do.
Okay, so now, Peter, what's your take on this? And how do you manage compartment as well if it comes to you? And when do you do the fixations along with it?
Yeah, that's again a challenging situation. We are all aware that when you do get compartment syndrome, then it's a delicate issue in terms of the viability of the soft tissues, minimize the risk of infection, etc. So if the compartment syndrome normally will develop the first 24-48 hours. So you need to watch even 3 days down the line. This is normally when you get all this excessive bleeding before the hematoma will form the blistering, the quite substantial amount of displacement of the fragments, which all contribute to this. If compartment is early and I do fasciotomies, then I will try at the time of the fasciotomies, if I can improve the fixation, I will do it at the same time. For instance, I can put some screws to create an articular block and provide, it's an opportunity to do something. And if you've got good management of the soft tissues, if we will need a rotational flap, I don't know if because of the swelling you're not going to close, all this is debatable, then I do it little as possible fixation, and then when I will have to go back, I will have to consider to use fine wire fixators after the closure of the fasciotomy wounds and so on. I don't try to fix and put the plates exposed with a vac pack and so on, because then usually you are looking for trouble. As long as I've got at the time of that I did the fasciotomy a good overall anatomical kind of let's say positioning, then I'm happy to go back when the fasciotomies will be closed, or when I will close the fasciotomies. If I can do it, then when I will do it. So I don't do routinely the fixation at the time of the fasciotomies. It might be that I will leave the X-fix, do the fasciotomies, and when I go back, if I can close, then I will fix it and close.
Yeah. Sanjeev, your take? Do you change your fasciotomy incisions sometimes for accommodating the fractures fixations?
Okay. I mean, these are complex, highly individual situation, and it's very individual dependent thing. Of course, if you had fasciotomy, you don't want to kind of go in while it's open. And so I've had one case actually who ended up having amputation, but a similar situation. Knee fracture dislocation, fasciotomy, got a foot drop, vascular injury, got infected later on. I mean, infection though healed, but eventually he opted to go for an amputation. So they are tricky, really. So I think key for these fractures is the key principle is do no harm, really. That's the key principle. you have to minimize, you have to weigh risk and balance, and you have to minimize possible complication. You definitely don't want an infection because that burns any future intervention, any future things you may do. So if you get that situation, I want to do the minimal possible, the limited thing, and the key is to maintain alignment. If I can get the alignment right, there are options, there's no infections, there are things you can do in future. Okay, but if you don't get the alignment right first and you get infection, things obviously you're now on a slippery slope.
Right.
I would do limited surgery, limited fixation with kind of a laser oven. So that would be my approach to these patients.
Okay, Samartha and Dr. Pushkar, any different thing or something which you would like to add?
Sir.
Yeah. Yes. Yeah.
Pushkar. Just immediate. Definitely, as the X-ray shows, there was a gross soft tissue injuries involved. Even like Dr. Mukesh is very experienced and he do much faster than among us also. These kind of procedures. So just a cautionary note, even if we are tackling these kind of fractures in 2 weeks or whenever the initial swelling has subsides, that time also we can plan, we can scan our procedures. Like initially we can go posteriorly and maybe 4 to 5 days later we can go anteriorly at
okay. So you want to stage
if we are able to complete the first procedure on the first time, and we can take the help of a plastic surgeon with us, because these kind of injuries most commonly ends up in kind of infections also. So take care of soft tissue is more important.
Right. That's a great point. I think Mukesh and Peter, you would agree with this, that if you feel that your soft tissues are not, maybe when you are doing prone and supine, you can also stage that fixation as well, while keeping into account that your column fixations are unilateral and they are not impinging on the opposite side, just like you have done, putting in smaller screws and smaller plates.
Yeah, you need to have options. And when you've got these explosion kind of injuries, you need, for me, the key issue is to get the patient early, put an external fixator, scan plan, as we say, and then if you tackle the soft tissues, then you can do anything. You can go, posterior medial incision, posterior lateral, anterior, anything is possible. Yeah. The key issue is when you do your incisions, not to compromise the next, procedure you may have planned to do, which will be, a catastrophe for the patient care.
Yeah, Samartha, do you want to add something?
Yes, sir. Sir, these are very devastating injuries. So I would be very wary of going in and operating before second or the third week. Maybe these are fractures where I would wait even more than 3 weeks before I go in, because I want my soft tissues to be absolutely all right. I would want this to be my first case of the day, because I don't want this at the end of my list and me not at my own personal best doing this case. And yes, I agree, if I'm struggling with the case and it's already 3 hours into the case and I'm only done with the posterior medial corner and the anterior medial corner, then yes, I would want to stage it into another stage. But the only risk we're doing that is if I stage it, then like Dr. Mukesh sir has done, he's put in very small plates with very small screws into the medial condyle. And usually whenever I would want to operate these patients, if I do go in medially or posterior medially first, I fix these fixations, then I go into the posterior lateral or the lateral corner. Once I fix those corners, then I come back to the medial side and increase the length of my proximal screws, usually to get a better hold onto these fragments. And I know this is easier said than done in this case. This was a very difficult case to start off with. So yes, I agree with staging, but then I prefer to do it in one stage.
Okay, fine. Point taken. Peter, what is your take on using three-dimensional first getting? You have 2 or 3 weeks with you right now in between, getting a 3D printed model of this and trying to see how exactly can we go in for fixation. In your Leeds University Hospital, are you using the 3D printed models for such complex cases?
No, we don't use it. I play a lot with our PAC system and the 3D modeling and so on. And if it's that complicated,
Yes.
I am an old-fashioned surgeon where I draw the fragments and then I just make a plan in terms of how I'm going to reduce it, where I'm going to put the screws, and so on. I appreciate that there are setters that they're doing that. They have found it helpful and so on. But I think it's nice to have it in front of you. But if you do all the work previously, I'm not very sure it will help me that much that I cannot do the work.
Yeah, I think it's useful to get a three-dimensional orientation for that, but ultimately reduction has to be done by you itself right on that ground stage. And maybe Mukesh Jain is the one who can do that. So I would just like to ask you one more thing regarding this, that you use two fixators or two distractors, two pins on either side. Was it to get a uniform sort of a distraction in the initial stages?
Actually, the idea of putting two distractors was little bit distraction on both sides, and then use it as a hinge. Like you have fixed the medial condyle, because your medial condyle is a floating injury at the moment because it is not fixed. So you cannot distract on the lateral side. Similarly, if you have a patient where you have a highly comminuted fracture on the medial condyle, you cannot fix it. So in those particular cases, if you want to use a distractor, you need distractor on both sides.
Right. Point taken. So thank you, sir, for that wonderful case and the wonderful discussion. And now we can move on to something which is having those bony injuries, but also added soft tissue injuries as well. And Dr. Sanjeev Anand, please, for your talk.
Thanks, Vivek. Okay, can you see my screen?
Yes.
Okay. So I'm a soft tissue knee surgeon. So my approach to all these injuries is very much from the soft tissue side. And I was asked to bring cases with the soft tissue reconstruction or element of soft tissue pathology which needs to be sorted. If you don't mind, can I just, there was a question asked by, was it Dr. Pradeep, about when you do anterior rim fracture, can you leave the I think for me, as a soft tissue surgeon, the take would be, if your meniscus is unsupported, you would want to support it. So on the lateral side, there is actually a lot of tibia is uncovered. And if you've got extreme kind of anterior fracture on the lateral side, potentially you can leave it. While on the medial side, it's less, you want to support the meniscus. So more often you do need to kind of elevate and fix. I don't know if that answers or actually tries to answer that question. So you need to support your meniscus. But this fracture it's a common pattern. I'm sure you've all seen this, and it's being increasingly recognized. It's posteromedial plateau fracture. And what I find in my practice is a posteromedial fracture quite often there's an associated element of ACL avulsion. And whether you fix it or not, that's something, it's a kind of a decision-making process, but it's a common injury. And I'm just trying to show my approach. So you get X-rays, which, this is again, we get patients transferred from other units, and X-rays don't tell much, as we all know about these fractures. So if there's an X-ray in plaster, you can't really tell much what's going on. But hopefully, the CT, so images gives you an idea. There is a posteromedial fracture, mainly posteromedial, and there is a ACL avulsion. Does that come through?
Yeah, we can see that.
Okay, so I've got the key images over there. Essentially, there's a posteromedial fragment and there's a ACL avulsion. He's a young chap and quite active. He's been involved in an RTA, and there's a displaced ACL. So if you're fixing posteromedial, I don't know what's the rest of the faculty's approach. Would they go to fixing ACL at the same time, or they don't do it?
And Dr. Pushkar? If Pushkar is not there, maybe Dr. Mukesh Jain, what's your take on taking care of these soft tissue injuries?
Yeah, see, these fractures are very classic fractures, especially with the Moore's classification. They can be classified very well, and their understanding is by Moore classification rather than Saska classification. So for me, these all injuries, I treat them posteriorly with a posteromedial incision. I fix them, and whenever there is a fragment anterior, I can take, if it is a big fragment, I can take it from posterior side. And that is called as Robin Hood screw. It's a Robin Hood approach where you just hold this fragment and put a screw from posterior to anterior. If these fragments are comminuted or these fragments are small, you cannot fix. So the literature says that only 30 to 40% fractures with a large chunk, you can fix them from posterior side, otherwise not. And if they are too thin and too small to comminuted, I leave them as such. I just fix the posterior middle fragment for posterior side.
Okay. So my take is, so I'll just show what my take is. If it's a posteromedial fragment with a large AC, so I have a different approach really. So when you go on a posteromedial route, it's very difficult to do the anterior ACL avulsion. At least I find it very difficult because I'm not as skilled as you are. So I kind of come up with this approach which I use and which I hope it shows really. So, and this patient, the one we had before, he had a posteromedial and anteromedial fracture. And of course, the ACL is a displaced ACL. And the reason is quite often these posteromedial injuries have an associated anterolateral. And I'm a lazy surgeon. I hate kind of turning them prone and then turning them supine, especially when I'm doing the lateral reconstruction and I'm doing augmentation as well. So I do them in supine position. So it's kind of like a supine. So I make an incision kind of along the posterior edge of the posteromedial crest of the tibia. And you've seen these hamstrings over there. So I isolate them. So I make a window above that. You get to the semimembranosus. You kind of move the popliteus away from the posterior border of the tibia. You get enough room to put a posterior plate. And you can put an anterior plate as well. And then from the same incision, I make an arthrotomy, kind of anteromedial arthrotomy. And from that, I can get a really good exposure for the ACL stump. And I use generally either can put a screw, and I'll show you some pictures, or use a Jain needle with ethibond sutures, and I use that to pass kind of sutures through the base of ACL stump. So this one patient, I've got put screws, sutures through the ACL stump, and you pull them down, and you can fix it on the proximal tibia. I'll just quickly show a couple more just example of that. So this picture, you can see the same thing. We're going to put a posterior plate. There's an anterior arthrotomy to the same incision. You get the sutures, and you can see the sutures coming through, and you can pull them through the proximal tibia and tie a thread. Pretty much, this is a common injury, and there are lots of cases like that. You can put a screw if you want to, or you can put a suture. So, and the reason, as I said, I mentioned, I don't always do MRI because you can see that ACL avulsion, this is not that much displaced, debatable whether you need to fix it or not, but it's easy enough. You might as well put a screw in, or you put a suture through that. And the reason I went on to this approach, because I'm seeing a lot of cases with the posteromedial and anterolateral, and this gave me an approach I could fix posteromedial and anterolateral in supine position all at the same time. And that's the sort of thing, and that's my take on these fractures.
Okay, right. Thanks, Sanjeev, for that great presentation and a new component which has been, because many of us out here, it's difficult and we don't appreciate the soft tissue injuries which are associated with tibial condyle fractures many a times. Any specific question from anybody out here? Okay, so I would just like to ask you regarding your rehab process when you are dealing with this, and what exactly is the rehab? Because when soft tissues and bony structures come, then some people will have problems dealing with the rehab.
Okay, if it's ACL, then I'm not worried about the rehab really. You pull it down, you've got a good fix, and it's really, and ACL is more isometric here. So when I have a fracture with ACL, my protocol is very much fracture dictated. When it's collateral injury, then I think it's more collateral injury, except for the weight bearing, which is dictated by the fractures.
So you will put the patient on a hinge brace for initial 6 weeks to 3 months?
They're all on a hinge brace. They've got a free range of movement start straight away. Right. Weight bearing is dictated by the fracture. So I delay weight bearing depending on the comminution and how much support I need for the fracture. So weight bearing can delay easily 6 to 8 weeks. But the movement is started straight away, especially in the ACL. There's no reason to delay range of movement in these patients. That the stiffness is, of course, you want to avoid stiffness.
Right. And one more question right here, because you deal with the soft tissue reconstruction part a lot, is let's say that you have an MRI with you which has already been done, and it shows a lot of meniscus which is torn or having some cuts and the tears which are there. So do you specifically, let's say in a type 1, 2, 3 sort of a Schatzker fracture, do you really you want to do and address them right at the time of fixation? Those tears which you see on the MRIs, or what? How do you assess which one to fake, which one to do something about?
Yeah, so I mean, there was a work in which I started kind of early in my career to doing arthroscopic surgery at the same time, and you see these root fractures, and you think it's more of a root tears.
Yeah.
I mean, the front is not really an issue, and you want to do a fix it or not, but it's quite messy really doing arthroscopy. There's a fluid extravasation. Even if you want to do a kind of dry arthroscopy, it just kind of there's the team kind of set up, the people who are well versed with arthroscopy, they may not be there with you in trauma. So I don't, as a routine now, do arthroscopy primarily for my tibial plateau fractures. It's just more for the convenience. So if there are kind of meniscus root tear, I might just address the fracture and see if they need anything later on for the root tear. Some root tears I've repaired primarily when I'm doing open, I do from outside at the same time. And I have cases where I can show that. But as a primary thing, I would let that be and see if they have any symptoms. I might deal with the root tear later as an arthroscopic thing. Often they don't come back to me at all. The rest of the meniscus tear is easy to deal with, even a radial tear going through the fracture. You got a submeniscal arthrotomy, you prepare them from outside in, and it's very easy to deal with. I put sutures, kind of stay sutures to the meniscus rim, lift them, look at my plateau, and when I'm kind of finishing the surgery, I use the same sutures to a Mayo needle, and then into the capsule and bring it down.
Okay, fine. Just one more question, which will be addressed to all the faculty as such. As many a times we have nowadays, it was said that medial condyle is a very compact bone and it is not going to fracture in a sagittal manner. But many a times we find that the medial condyle is now split into two, which is in a sagittal way. And the MCL is lying just there. How exactly do you try to reduce that fracture when your fracture is right there? Because on the lateral side, you can go in and take out things and look out. How do you deal with those fractures? Sanjeev and then Peter, Mukesh, anybody can say.
So, okay, if you don't mind, I'll start.
Yeah,
so
sure.
It's not unusual. Thing is, fracture patterns, when the fractures happen, they don't read those classifications. They don't follow books. They can happen anywhere. That's a joy of trauma, isn't it? Yes. So you get oblique fractures, which are going right through your MCLs, and now you're trying to see how to see the reduction. That becomes really tricky. And look, I kind of protect key ligaments, key structures, both either on the medial and lateral side. And I make windows in front of those key ligament, key structures, stabilizing structures. So if we have a fracture pattern like that, which is going right where the MCL is, so my one window will be submeniscal in front of MCL and another window will be submeniscal behind MCL. And these ones, quite often you're doing an indirect reduction. So all these fractures, there's a kind of like an inferior kind of triangular spike comes with, especially the posteromedial. And so you got these two windows, submeniscal windows, and then you got the posterior surface of tibia exposed. And if you can get the spike to wedge where the kit had come from, and you get the line right, you would think you would most often you'll get a reduction right. The difficult bit is these things only reduce the posterior when you extend the knee. They won't reduce in knee flexion. And as you extend the knee, your soft tissue windows close. So your exposure suddenly becomes really small. And that's something, of course, you have to keep an eye out. You need to maintain your exposure all the time and, of course, maintain the direction of the screws you put in.
Yeah. Peter, would you like to add to it?
Yeah, I mean, what Sanjeev says is quite helpful. It makes sense and also allows you to navigate from one window to another to respect the soft tissues, not to detach completely whatever is attached to the fragment and create more problems. I think every fracture is different. You just need to be versatile, utilizing, the way that the fracture is done to actually open it up and see what you want to see in terms of the intra-articular structures and then come back and put it together is never easy. I have to admit that. But, putting some wires across the different fragments, holding together, and then being careful with your maneuvers, it facilitates the reduction of the fragment with the ligament or anything else in such a way that will make it easier for you to keep the alignment and fix it afterwards. So I don't have any other specific tip to tell you, but that I use also some fine wires to keep the fragments aligned and to maintain the reduction.
Right. Dr. Mukesh, please.
Yeah, I fully agree with that. The only thing is, for me, apex is the most important thing. And that is the reason I switched over. Rather than going from supine, I started going prone position to find out the apex and to fix it rightly. And second important thing, hyperextension and valgus. If you do these knees in hyperextension and valgus, with the spike in the right place, probably you will not be in a problem. And then you buttress it.
Pushkar or Samartha, would you like to add something to it? Okay, so there are two questions which have come to me from the delegates who are watching this. And it has been a wonderful discussion on a very complex topic of proximal tibia, I must add. Regarding the raft screws, in the proximal tibia type 1, 2, 3, when we are putting in the raft screws, is there any specific thing that where exactly do we put them? How below the articular margin that we need to put that? Number of screws or any size of it? Peter, would you like to answer that?
So in terms of just repeat, please, what you are trying to say about the raft screws is what?
Regarding the type in the lateral tibial depressions, when we lift them up, is there any specific distance from the articular cartilage that we need to put those screws, or at the subchondral level, 5 millimeters below the articular cartilage or something? And the size of the screws that we need to put, or any size can do the thing.
Yeah, well, if you've got enough subchondral bone and there is a big fragment, then I would like to connect the two blocks. So what I would do is I would put a 6.5 screw to compress it and give a good hold to the articular surface, because you need really good stability. And then below that, I will bring my plates, which, that's how I would do my reconstruction. And then below that, I will bring my plates, and then it will depend how much of void you've got and how much of bone substitute you need to insert. Normally, as you said, 5 millimeters below, maximum 1 centimeter to put the raft screws, but the raft screws will have to go just below where was this cancellous bone impaction to support whatever you reconstructed anteriorly. So it's between 5 millimeters to 1 centimeter, I would say, but it comes down to how much of subchondral bone you have there, where you can purchase it or not.
Right. Point taken. And the other question which has come is that there are now many companies which are coming with variable angle plates and variable angle screws which are coming up for different fractures, even for proximal tibia. Your experience in using them and any specific indication or contraindication for such type of plates? Maybe Mukesh, Jain, sir?
I don't think there is any use of the variable plates.
Okay.
You can do your job the way you want with the similar plates.
In acute setting, even in
anywhere.
Yeah,
You
right.
don't need it.
Anybody else has a different opinion? Yeah, Pushkar? Yeah,
Sorry.
unmute yours. Yeah.
Regarding the raft screw first, we need to have a stable outer cortex. If it's fractured somehow, so you add on with your plate, with your locking plate. So that is essential for putting any raft screws. So either you have an intact lateral cortex and an intact medial cortex, where the two ends has to be stable where you are putting your rafts. So one thing important. So I think with the plate or your condyle has to be stable so that you can put your rafts there on a stable ground where your subchondral bone, the depressed bone which you have elevated, has to be stabilized. Second thing is you have to have that subchondral bone. If you are opening it up and putting that subchondral bone as much as you can, so you have to have your screws adjust where your subchondral bone is, maybe 4 to 5 mm or maybe more. The more the better, so that you can have a stable bone where you can place your raft. That's regarding the raft screws. That's my suggestion. Second thing is regarding the variable. You just
Pushkar, your net seems to be slightly unstable.
more options to posterolateral corner. Sir?
You can just repeat what you said regarding the variable.
Okay. As the Mukesh sir has shown his very comminuted fractures where he has gone through posterior-medial, then posterolateral corner was also injured badly. There we can use the help of a variable angle if it's there to support from the lateral side my posterior lateral corner, so that I can get a space to go from the same end to more posteriorly if I can guide from that end, but not specifically. It just get more angle where you wish for.
Right. Thanks. Samartha, you would like to add, because we know that we are having a study on that. So maybe you would like to say.
Yes, sir. So I agree with most people that generally variable angle plates would not be much of a benefit in proximal tibia fractures. But then when and we have a randomized control trial going on under your guidance, chief guidance at our institute regarding the two plates. But then I think till now, from what I have experienced, I think especially these posterolateral tibial plateau fractures, when they're fractured very high up, with a lot of depression there, we need to take the plate very high up to the tibia rim. And whenever we look at an AP view of these X-ray patients intraoperatively, it seems that the plate has crossed the joint line when it actually has not, because it is posteriorly very superior. And this is the time when I think with a variable angle plate, I'm more comfortable. If there is a depression, I'm not talking about a shear fracture. When there is depression, these are the situations when I would be happier to use a variable angle locking plate, when just for the peace of my mind and just for critique of my X-rays, when AP view is done outside, someone, even though I know intraoperatively these screws are not going intraoperatively, but then it will be helpful to have a posterolateral plate with a variable angle screw. And also when, like Dr. Mukesh Jain sir showed a case wherein all the four columns, posterolateral, posterior-medial, anterior and medial, anterolateral, anterior-medial columns are fractured. These are situations whenever one of the four columns has a major big fracture chunk, and I'm trying to get away just putting plates on three columns. That is the time, especially on the posterolateral column, if I don't want to, if it is a big chunk and with a lateral approach, I've looked at the posterolateral surface and brought it in contact and good reduction with the anterolateral surface, I don't expect my anterolateral plate to get a good hold of the posterolateral fragment. And they usually tend to have a split, coronal split of the medial fragment anteromedially and medially and posterior-medially. And posterior-medial plate screws cannot go into the posterolateral corner. And when we are trying to shoot in medial screws into the posterolateral corner, it just does not happen. So in this situation, if I put in a medial plate and I have a variable angle plate, then I can use that same very plate to hold on to my posterolateral.
Yeah, so there are some situations when you have some specific fracture pattern, and as Sanjeev said, that the fracture does not follow the classifications. So for sometimes, in some situations, we might be needing a variable, but mostly the role, as Mukesh sir has said, we can get away with fixing with the angular stable fixations. So now I'll go upon to my presentation, and I think it's visible now. Yeah. So I'll just start out with after the cases shown by Dr. Mukesh and others. It is relatively a simple case, but this is what the case was. It was a case of a 34-year-old RTA and a patient who was having this sort of a fracture. And I brought about a simple case, so just to bring about the various approaches and the fractures and how we can deal with them. As we have discussed, the X-ray does not show relatively much, and in present-day world, CT scan has become the mainstay of investigation and further planning and diagnosis. And what we see here is that we have different fractures, anterolateral, posterior, medial, anterior, along with various sort of combinations and the posteromedial combination as well. This is what the CT scan showed. And we can see that it's big chunks broken into 3 or 4 parts. Relatively a simple, complex case for most of the people who are dealing with trauma. These are the 4 fractures. So I would like to bring about the questions which most of the delegates have been asking. And thing is, how do we delineate the major fracture fragments? We can get it in CT scan, as we have seen in the axial sections. But how do we decide which fracture and which fragment requires fixation? Do we fix all the fractures that are there, which we see on a CT scan? And that's my question to all the faculty as well. Pushkar, would you like to answer that? That which fragments, and when you see a CT, how do you decide which fragments are going to be fixed? You can unmute yourself, Pushkar. Pushkar, can you hear me?
Sir.
Yeah.
So sorry. Which fragment to start with? So I will start from the posterior side, posterior lateral. If I am fixing
No.
in this case,
I'm not saying about the fixation, which approaches we are using.
Sir.
I'm just saying, let's have a CT scan. Let's go back and see the CT scan.
Yes, sir.
And if we have this axial scan, how do we decide? Are we fixing all the fractures with a specific plate, or how do we decide fixing these?
So now, because the plates have changed from that large with 1 to majority in the 2 to.
Your net appears to be unstable.
Now
side.
we start. So that when we are fixing, starting from the posterior side, it should not hamper my anterior fixation. It needs further reduction there. So I'm just start fixing from the posterior side. So in my thinking, I will start from all the 4 fractures on a separate plate fixation.
Okay.
In these, maybe posterior.
Yeah, that will decide. Come to later. So what we are thinking about is the fracture or fragment specific fixations that we are dealing with, and maybe Peter or Sanjeev, can you put on that question? That many a times we have a lot of comminution and smaller fragments of, let's say, 1 centimeter cortical breaks, 5 fragments. So how do you decide which fragment, and do we need to fix all of them with a rim plate sort of a thing, or what do we do?
You want to answer, Pete, or should I answer?
Yeah, you need to
let Pete answer first.
If we think the plateau that it has 3 major columns, the lateral, the medial, and the posterior, okay, then
Yes.
you need to ensure that, and of course, each one of these columns may have sub fractures which go through that column, right? So my approach would be that I would try to reconstitute each of these columns and connect the fragments together to make one piece for the medial, for the lateral, and the posterior column. So you may, and then the issue is, so you need to decide how you will, of course, your approaches, and then how you will connect the different fracture fissures going through each column so that you can create a stable column which will be able to withstand the loading and shearing, and at the same time to maintain the reduction. Otherwise, you will not going to have congruity, you will have instability, and that will lead to post-traumatic osteoarthritis.
Okay. Right. Yeah, Sanjeev, you want to add to it?
I think, if I'm being honest, really, the decision-making sometimes in some of these comminuted fractures, there are 3 different factors I'll take: patient factors, fracture fractures, and of course the surgeon factors as well. So that may help me decide which one to fix. If it's a kind of patient with low kind of demand and older patient, there are things which I may ignore compared to somebody young, active. So that patient factor you have to keep in account. In a fracture, of course, then there's a surgeon factor as well. But if you're just going by the fracture, I think most often if there's a big chunk which provides stability and they're worried about the risk of secondary collapse, those you definitely want to fix. So posteromedial, I would definitely want to fix. Similarly, large depressed anterior fragments, I would definitely want to fix. Posterolateral, occasionally I may leave. A few reasons. One, fibula is there, which provides support, and the risk of secondary collapse is low. Second, it's very difficult exposure, and getting the right reduction, sometimes it may be difficult, especially when there is a very comminuted fragment. Even if you get it, there's a very high risk of you may not actually achieve much. You may get a good X-ray, but whether you achieve much is difficult. So those ones are, but not all surgeons are well versed in fixing those as well. Posterolateral are the most difficult ones. Rest are, fortunately, I mean, most of us get trained to the right. So that's the surgeon factor. So I think those three factors do help decide which. Okay. I don't know if that answers.
Okay. Dr. Mukesh, anything, or should I go ahead?
I think Sanjeev has answered beautifully everything.
Right.
Only thing for me is the medial condyle is the crux of the whole fracture. No compromise with medial condyle, no compromise with the lateral condyle depression. Rest you can forget.
Okay.
The key issue to remember is that you need to take into account the degree of displacement. If the degree of displacement, whether it's lateral displacement or posterior displacement or whatever, is substantial, you cannot leave it.
Okay.
Right? Because then you've got instability. So all what we're discussing is relevant to how much of displacement you've got and how much of lateral explosion you've got. Because at the end of the day, even if it's a difficult approach to do posterolaterally, you will still have to do it to address it.
Yeah, no, I agree, Prof. We have to do it. It's just that if there's not much displacement and you have to choose one, I think that's the one that might.
But then you can fire some screws front to back and address that segment as well. So it's just common sense. And also, of course, we need to remember, do no further harm. A bit of a step, the tibial plateau is a well-tolerating joint for post-traumatic osteoarthritis.
Yes.
So you can have a 4 or 5 millimeters and you can still have the patient going for 10, 15, 20 years without any substantial, functional impairment.
Yeah.
Right.
Can I just add on, sir?
Yeah, sure.
So this is based on what I've learned from you and the big Kongfeng Luo paper that came up after 2010, the 2014 paper. So the answer is, I would just go back and look at the X-ray from the last slide. That X-ray shows, so the first X-ray when patient comes to me, the AP view clearly shows this is a valgus injury, this is not a varus injury. So the compression side is on the lateral side. So I would definitely plate the lateral side if I have to choose the sides which I have to plate. And then I will have a look at the lateral view. The first lateral view, if it shows it is an extension injury, I would definitely put in some anterior plate, either anteromedial or anterolateral. And if it is a flexion injury, I would definitely put in a posteromedial or a posterolateral plate. Okay. So if there is doubt about the number of plates, then the both AP and lateral view, whatever is the compression side on both, plate those two at least.
Right. So I go ahead by saying that, yes, you look at the classification, look at the type of mechanism of injury, try to fix what is displaced and which is going to contribute to the stability of that joint. Maintaining the alignment remains the key. Articular depression can take a slight backseat as compared to other fractures or intra-articular fractures. Now let's come to the next question, is which approach to use when you have to deal with such fractures. I think that most of us use the posteromedial anterolateral approaches. And let's say that if it is just a posterior fracture, because most of the fracture was on the posterior side, then what are you use the posteromedial approaches, or you use a separate posterolateral? How exactly do you deal with these cases? Dr. Mukesh, please.
See, for me, I always think if the 60% of the posterior side is involved, I can treat those fractures only from the posteromedial incision.
Okay.
If I feel that the comminution is going on more on the lateral side, though you cannot treat from one medial side, then you have to put either a straight single incision, or you can have two different incisions, one from medial side and another lateral side, depending upon the depression of the fracture, whether it is a posterior or it is a posterolateral or it is anterolateral. Depending upon that, you make the second incision posteriorly.
Okay. And how many plates we have already seen that whatever fragment requires and contributes to the stability and alignment, that's what requires a plate or fixation. So that's what one of the faculty was discussing, the Kongfeng paper, which shows the column fixation and the fragment specific fixation, that has looked at the CT scans and tried to look at the axial sections. And this is the most commonly used, or if not the classification, at least this is the section which most of us use to look at which fracture fixation and what sort of fracture fixation needs to be done. So in this, how to proceed was our thinking. And what we decided was that, yes, these are the three major fragments. This is the anterolateral one, medial, posterior, and this fragment would get fixed with all the fractures. As Peter was saying, that all the fractures, we do not want fragment-specific fixations which remain separate to each other. All of them have to combine together to give us a ring congruity and a containment of the proximal tibia fracture. So that's what we planned to put in these things. Lift this up and put in a graft, and lift this up and put in the raft principle. So this is as a simple fracture, because there are questions from the delegates of how do we do this approach. Let's say that this patient, how do you deal with, if I can start with maybe Pushkar, how do you deal with these fractures when you are majorly dealing with the posterior fracture patterns? Do you take the patient in a supine position with a figure of 4 sort of a fixation for posteromedial approach? Or you take two separate, as Mukesh Jain showed, prone first and then take a supine position? Pushkar?
Sir, is it audible?
Yeah. Slightly louder, please, if possible.
Right. Sorry. If in a simple fractures like you have shown with a posterior medial single large piece, so I will prefer to be in a supine. Then I can deal with the lateral side. If it's a large combination on the posterior and involvement of the posterior lateral also, where I need to go more deeper, then I will take the patient first prone and then prefer to turn him in a supine later. But if it depends upon how much the combination position, how much work I need to do posteriorly. If it's a large, then I will go with the single approach in a supine position with the posterior medial side.
Any different opinion from UK or from Muzaffarnagar?
See, for me, after going so much of experience, I have got